We all know that oral cancer is a major health problem worldwide. And in case of head and neck cancer, 90% of the cases are squamous cell carcinoma and its variants. Regarding the etiological factors, the chewable tobacco, areca nut, alcohol, smoking, betel quid are the major and well-established risk factors for oral cancer. But however, 15 to 20% of the patients do not present to us with risk factors using these above mentioned risk factors. So there might be a new etiology. There has been numerous studies which have shown that high-risk type of human papillomavirus has been strongly associated with significant proportion of the cases of oral cancer. And there is a dramatic rise in the incidence of HPV-positive oral cancer recently in the last 30 years. There is variations regarding the geography, gender, and ethnicity, but the cases are rising by 5% each year. And although fundamentally the same, there is clinical and histopathological differences and differences in the treatment outcome and prognosis between the HPV positive and HPV negative oral cancer. I'll not be going into the details. The aim of my study was to find out the proportion and clinicopathological features of HPV positive oral cancers in patients coming to our center. This was a cross-sectional study which was conducted in Department of Oral and Maxillofacial Surgery, Dhaka Dental College and Hospital from January 2019 to December 2021 with a sample size of 55. This is Dhaka Dental College and Hospital, which also houses my department. And to this day, our department has been constantly giving treatment to oral cancer patients. We included patients who were clinically and histopathologically diagnosed with oral squamous cell carcinoma. They underwent a standard surgical protocol, and they did not require any concurrent surgeries. And we excluded patients with uncontrolled comorbid disorders, and the patient who underwent previous surgery for oral cancer or received neoadjuvant therapy, and we also excluded the recurrent cases. HPV detection was carried out by P16 immunohistochemistry, and the cutoff value of 50 was used to divide the patient between positive and negative results. I would like to share some pictures of the immunohistochemistry slides. This is 30% immunostaining, this is 60%, and this is 80%. Going on to the demographics, the mean age of my patients was 55 years, and 60% of my patients were female. And regarding the number of the partners, as we know, Bangladesh is a conservative country, and majority of the population are Muslim by religion. And due to the social stigma, people are very reserved to express the number of their partners. But there is evidence of practice of polygamy in the rural region, and also people move to the foreign countries, they get married, and when they come back, and they get married in this country also. And the females also get divorced and remarried. So there is evidence of multiple partners, but it is very difficult to find out. Now coming to the number of the age of the sexual debut, the average age of sexual debut was 23 years, and regarding the habits, in Bangladesh, most of the people in our center, most of the patients we get are from the rural areas of this country, so they have a habit of betel quid chewing, but that's why the percentage is higher, which was 56%. But here you can see I had 12 patients who had no such habits, so which was 20% of my sample size. And regarding the site of the lesion, the gingivobuccal sulcus was the most commonly affected site, and followed by the retromolar area, which was the second most common. And clinical TNM staging, stage 4A was 72%. I would like to share some pictures of my patients. These are the lesions involving the labial mucosa, and also the lower gingivobuccal sulcus involving the alveolar mucosa, and also the right figure is showing the lesion involving the buccal mucosa. These are next picture is the lesion involving the upper gingivobuccal sulcus, the verrucous type lesion, and the lesion also involving the upper alveolar mucosa, and sometimes we get ulceroproliferative lesions involving the buccal sulcus. And we also get lesions which involve the palatal mucosa, and from that extends to the gingival alveolar mucosa, and sometimes the whole hard mucosa of the hard and soft palate. And sometimes we get patients with very inconspicuous lesions and with restricted mouth opening. And for example, this patient had a lesion in the upper posterior alveolar mucosa, and we get leukoplakia, which turned out to be invasive squamous cell carcinoma, which are extensive and involves the whole mucosal region. And we also get patients with ulceration of the tongue, especially in the lateral border of the tongue. Regarding the pathological TNM staging, 45% of my patients were stage 4A, and grade 1 was 63% of the patients. And regarding the result of the P16 immunohistochemistry, 60% of my patients had a positive P16 immunohistochemistry result. Now, considering the association of P16 positivity with clinicopathological parameters, first of all, regarding the age, among my positive cases, 33% of my patients were less than 49 years of age, and 63% of the positive patients were female. And as I was saying earlier, that it is very difficult to find out the number of the partner. And regarding the age of the sexual debut, among the positive cases, 66% of my patients were less than 25 years. Regarding the personal habits, I would like to, I have said earlier that I had 12 cases with no habits of using betel quid or alcohol or smoking. And here you can see that I had 21% of the patient who had came up with positive result. Regarding the site of the lesion, although the gingivobuccal sulcus and retromolar area was the most commonly affected area, but if you look at the rightmost column, here I had 8 cases of CA tongue patients. Among them, 7 were positive, which was 21%. Now coming to the clinical TNM staging, among the positive cases, 66% were stage 4A, and and pathological TNM staging, 51% were stage 4A as well, and 57% of the patient or positive patient were in grade 1. So although we have higher percentage of P16 positive patients, the chi-square test showed no significant association between P16 immunohistochemistry findings and the clinicopathological parameters. So I would like to take a moment to share this picture. In our center, we have very strict follow-up protocol, and with the supervision of my head of the department, Professor Ismotar Haidar Madam, and my supervisor, Tarin Rahman Madam, we conduct a follow-up protocol and a very strict follow-up program and documentation. So we had a few limitations. First of all, we had a smaller sample size that affected the generalizability of the findings, and this study was conducted in a single center, which might have limited the diversity of the patient's population. And as our country is a poor country, and most of the patients we receive are from the rural areas, they seek treatment first in their local from the local authorities and doctors, and they sometimes go to the homeopathic doctors, and they go to the religious figures or magicians. Then they come to us. So they lose a lot of time, and the disease progresses to advanced stages. So that's why sometimes this may influence the result. So at the end, I would like to say that oral cancer, especially in case of HPV positive oral cancer, is now considered a global burden, and it is feared that HPV positive oral cancer might surpass the other HPV positive cancers. And further studies should be conducted to find out the biology of HPV positive cancers, and so that we can generate a preventive measure and a definitive treatment protocol so that we can serve our patients more efficiently. Thank you for patient hearing. Thank you all.